مرحبا دم باش بهیوی مهون باش بن دبردوامی پروگرام می به اول می آیش دا ایرو سمینار که سمینار سرناو اپدیت آن سپسیس سرمجال سپسیس او سمینار تداوی سمینار کوتی دا اینجا عالی دکتر روشن صالح دکتر روشن صالح بخو اصلویج سلیمانیه لی آنها وکو اینترنال مدیسین یا سپوری داخلی در آلمانیا در کاردکا در هاسپیتال آف برادرز آف مرسی ترایر اگر من تلفظی شش کریه ببورم او سمینار تداین دکتر روشن تو کرم بکه دست به سمینار خو بکه و مامسا خونده کرم ایجا حاضرن.
Okay. Yeah, like fast. Yeah, my name is Roshan. Hello, everyone. As mentioned, I'm a internal medicine resident. I'm in my second year in Trier, Germany. And thank you very much for the opportunity to be part of this training session. I hope you take a few messages home today. Our topic for today is sepsis. We'll start very simple by saying, when an infection takes place in the body, you have three outcomes. Either your body overcomes it without taking any medications, and this is usually a mild viral infection or a mild bacterial infection, or you need to take antibiotics or other medications that help fight it, or in the most serious of conditions, we have what we call sepsis. So sepsis is basically this overwhelming response of your body's immune system. It is a dysregulated response that eventually leads to organ dysfunction. And this is the newest definition of sepsis. And in its most severe cases, it can lead to septic shock, and which we'll come to in a few minutes, and also to multiple organ failure. I'll start off with the pathophysiology. I think I changed this one slide last night after I sent it, but I thought it would be easier to understand if we talk a little bit about the pathophysiology. So what we mean by dysregulated immune response is that obviously when you have an infection going on in the body, you have your inflammatory mediators that are activated. And this is what leads to dilation of the vessels. You have pro-inflammatory cytokines. You have this metabolic process taking on, and this is what leads to disruption of your endothelium, and this is what we call capillary leak. You have edema, but then you have intravasal hypovolemia, and this is where people need fluids, and this will eventually lead to what we call a disseminated intravascular coagulation, where your coagulation factors are activated. And we'll come to that a little bit as well. But this is basically the process that leads to this dysregulated immune response. Your tissues are disrupted eventually. You have ischemia, you don't have enough oxygen in your tissues. And this is what leads to organ dysfunction. Throughout the years and throughout the past decades, there has been a modification of the definition of sepsis. How I studied sepsis is its definition from 1991, and it is the same definition that is still used in hospitals, even in the USA and even in Germany, also where I work. But it is very non-specific, this old definition of sepsis 1. It was long time ago, in 1991, it was thought of this sepsis continuum of being someone having an inflammatory response, and this would have 4 criteria with it. As like if you had, for example, someone had an infection taking place in the body would respond to it. And if this was coupled up with 2 of 4 criteria, it being temperature change of someone having 38 degrees or above, or 36 degrees or lower, if someone had a heart rate of above 90, if someone had a respiratory rate of above 20 breath sounds per minute, or if someone had a high white blood cell count or a low white blood cell count below 4,000. If you had 2 of these criteria, and if you had a suspected or approved infection, they would call this sepsis. And the thing with this is that it was very non-specific. You know, you would have patients who had other disorders and would have the same symptoms. And then they would classify someone having an organ dysfunction with this, they would classify it as severe sepsis. And then they would say, okay, if someone has such hypovolemia that it does not react to fluids, we would call this septic shock. And because this was very non-specific, in 2001, they said, okay, we'll need to generalize it a bit more. We're going to say that if someone has a suspected or a proved infection, and we'll focus now on organ dysfunction. So let's say if someone has a decreased urine output, if someone has an altered mental status, so we'd look at Glasgow Coma Scale. If someone has, for example, like I mentioned, this disseminated intravascular coagulation, where your platelets are also eventually low, you know, we look at the thrombocyte count. We look at if someone has petechia or purpura on their skin. They would look at the infect parameters, and this was the newer definition of sepsis. But this also got a bit complicated because there were so many factors involved in its definition. So in 2016, the newest definition of sepsis is what we previously talked about was, okay, it's a dysregulated immune response. There's organ dysfunction and there's a suspicion of an infection in the body. The thing with its newest definition is that it has been easier for it to be identified in the sense that it is more specific. You have a newer score. This is called the SOFA score, which we'll come on to right now. And this sequential organ failure assessment, where you would identify your organ dysfunction based on a scoring system. It is a bit complicated when you look at the SOFA score. I just wanted to also say in this slide, the newest definition of sepsis, sepsis number 3, they ruled out SIRS, so no one really has to talk about SIRS because it does not exist anymore, even though we still do. And also they ruled out severe sepsis. They said there is only sepsis and septic shock. If there's organ dysfunction, it's called sepsis. If there's hypovolemia that does not respond to fluid therapy, we're going to call it septic shock. So this whole SOFA score is a little bit complicated. And it's not very reasonable to use, for example, as an internal medicine resident in the emergency ward or in the emergency department or on a normal ward, because you're not going to sit down and look at every single lab result of a patient and see where the organ dysfunction is, because there might be patients who have previously had an organ dysfunction, you know, and but generally it is more often used nowadays in the intensive care unit to assess the level of organ dysfunction. So it's about assessing mortality of patients. Again, it focuses on your Glasgow Coma Scale with altered mental status. It focuses on your platelet count. It focuses on your kidney function, on your liver, on your cardiovascular system, how is the blood pressure of the patient, and on your respiratory system.
Sorry, Dr. Roshan, sorry, excuse me.
Yeah.
Sorry, interrupt you. I lost my connections. Can you restart these slides and a little slowly speak?
Yeah, sorry. Okay. So basically, the newest definition of sepsis focuses on organ dysfunction. So you categorize how severe the situation is, how severe the sepsis is, based on how much organ dysfunction takes place. So we focus on our nervous system. This is where our Glasgow Coma Scale takes place. We focus on our cardiovascular system. We focus on our blood pressure. On the intensive ward, it is your invasive measurement of middle arterial pressure, MAP. We focus on our urinary system, how much urine output the patient has. We focus on our liver function, because again, organ dysfunction, kidney injury, we look at our bilirubin levels. And we also look at our respiratory system. We look at oxygen pressure in your arteries. This whole SOFA scoring system is very complicated. It is not logical to use it in the emergency department or on a normal ward. when you have a night shift as a resident doctor. Because the thing with the diagnosis of sepsis is timing. Timing is very important. And because of this reason, they made this scoring system easier. So they said, okay, because this is very complicated, we're going to do something easier, and we're going to call it a quick SOFA score. And what they did here is they said, okay, if I have a patient that I suspect that they have an infection, or it can be even proved. For example, you do an X-ray of the lungs and you see infiltrations everywhere. The patient has fever, they have tachycardia, they have tachypnea. You see their white blood cells going up, their infection parameters are going up. They said, okay, if you have this infection in mind, and the patient has the following's present, then you can identify them as sepsis and start with your treatment. So they said, okay, if your blood pressure is 100 or less, if the patient has an altered mental status, and if their respiratory rate is 22 or more, if they have a tachypnea, then you can easily identify these patients as being in sepsis. This made it more specific. It made the diagnosis more specific because, like I said, previously with this SIRS definition and sepsis and severe sepsis definition, there were patients who were identified as being in sepsis who did not have sepsis. You know, there's a lot of differential diagnosis that we will also come to in later, which we always have to keep in mind, but generally this newer definition made it more specific for us to identify patients with sepsis. Am I still too fast, or is that okay? Am I too fast, or is this okay?
It's okay.
Okay. So what is the etiology? Where does this whole infection and sepsis come from? The most commonly, we have the respiratory tract, and that is the most common being pneumonia. What comes after that is your abdominal infection. So for example, let's say by a gallbladder infection, you have an abscess forming. You have your genitourinary tract, for example, a kidney infection, pyelonephritis, skin and soft tissues. These are what we tend to forget. That's why it's very important to check patients what is under the bed, and also implanted devices. This is also one that we tend to look into in the last place, because, for example, patients who have been in the hospital for a while, they have a urinary catheter. Patients who receive chemotherapy, they have a port implanted. You have patients who are on the intensive ward, they have a central venous line, they have an endotracheal tube, and these are all risk factors that could lead to an infection and eventually lead to sepsis. Our pathogens are different depending on where the infection in the body takes place. Obviously, the most common pathogens are bacteria. They could also be viral. They could also be fungal, but these are rare. We have gram-positive bacteria and we have gram-negative bacteria. And the gram-positive bacteria are usually responsible for the respiratory tract infections, and the gram-negative usually genitourinary, but also abdominal infections. I wrote down a few examples of what the most common pathogens could be. And this is very important because the antibiotic therapy in the long run depends on which type of pathogen caused the infection. What are the risk factors? Why is someone more susceptible to get sepsis and another not? It obviously depends on the age of the person. So people who are younger and people who are old, but also people who are immunocompromised, people who have diabetes, people who have a low immune system, who take corticosteroids, people who receive chemotherapy and have neutropenia, people who have been in the hospital for a long time. You know, when you're at the hospital, you have IV line, that can also be a risk factor. People who are on the intensive care unit, people who have recently received antibiotics, and like we mentioned before, people who have a port system, a urinary catheter, a central venous line. These are all risk factors that can eventually lead to sepsis. The clinical features of sepsis relate somewhat to our screening of sepsis. It differs, it varies a lot, but generally speaking, what we previously said before, someone with fever, someone with tachypnea, someone with tachycardia, you know, the organ dysfunction that we previously talked about, someone is not urinating like they should be, which is above 0.5 milliliters per kilogram per hour. So oliguria, someone who has a very low blood pressure that is not responding to fluid therapy, could lead us to thinking of septic shock. Someone who has petechia and purpura all over their body, someone who has jaundice, symptoms of respiratory failure, which is ARDS, acute respiratory distress syndrome, which can also be an end result of sepsis, where you have inflammation of the lungs and respiratory failure as a result of the fluid buildup in your alveoli. But you can also have features of septic shock. Like I said, you have refractory hypotension, you have mottling of the skin, you have decreased capillary perfusion time, but also features of a primary infection. So history taking is very important for patients who are oriented. Someone is coughing, someone has symptoms of a urinary tract infection, someone has abdominal pain and acute abdomen, someone has surgery a week ago. So history taking plays a very important role. And this whole clinical features of sepsis and its screening tools, you know, you don't have a gold standard. You cannot say, okay, if I have number 1, number 2, and number 3, then this person has sepsis. It is a combination of clinical features. It is a combination of your early diagnostic tools that you have in the hospital, that you have in the emergency department, which we'll also come to right now. One of the very most important follow-up of someone who is suspected of having sepsis is your lactate level. Lactate is the end product of anaerobic glycolysis. So that means when we have a high lactate level of above 2 millimoles per liter, this is when we think of tissue hypoxia. This is a very alarming sign. And I actually have a question, Dr. Haider. Do we have blood gas analysis in the emergency department in Syria, in Rojava? I think. Okay, maybe I'll ask that again later, because this is a very important factor. If there's one thing that we need to keep in mind after this this training session is the level of lactate when it comes to septic patients. Moving on to managing patients with sepsis. Number 1 is that sepsis is a medical emergency. Timing is very important. We cannot we cannot get too caught up in our diagnosis and forget the treatment of the patient, because we need to act very quick. The newest definition of sepsis of 2016 actually says that we need to start our treatment of someone who is suspected of sepsis within 1 hour. So from 1 hour of seeing a patient suspected of having sepsis treatment should have already started. That's why the screening of patients, especially those who are at high risk of having it, plays a huge role in the mortality rate of the patient. We obviously start with A, B, C, D, E. That is what we always start with when seeing a patient for the first time. Obviously, airway. The airways are free. Breathing, auscultation. Does this patient have stridor? How is their breathing frequency? Are they breathing too flat? Are they breathing too rapidly? Obviously, their circulation. Do they have an IV line? Are they too hypotensive? How is their Glasgow scale? Are they too altered? This is obviously the first thing that we do when we see a patient. And then we need to monitor them. So cardiac monitoring, pulse oximetry, how is their respiratory system? And then it comes to lactate. You know, a blood gas analysis takes a minute or two. When you take up your blood in order to measure your lactate level and how severe the situation is, you can look at your electrolytes immediately. You can look at your pH levels. Is this person having an acidosis? Because this is very important for the mortality. You know, depending on the severity of your lactate level, you have an up to 10-fold increase in your 24-hour mortality. So level of lactate in the first 24 hours of managing someone suspected of having sepsis is very important. The diagnosis that we take into action when someone is suspected of having sepsis obviously is your lab. This also takes a few minutes, looking at your complete blood picture, CBC, looking at your CRP, looking at your kidney function. Does this person have a shock lab result suggestive of, for example, if someone has high levels of transaminases and bilirubin levels suggestive of liver failure. This only takes a few minutes, so there's no excuse for not taking blood immediately from a patient, but also blood cultures. This also takes a few minutes. These are basic diagnostic tools that we need to do when we see a patient suspected of having it. Monitoring the patient is the next step. Obviously, how is this patient responding to the therapy? So the first thing that we do is, in this situation, is we give fluids. Like I said, intravascular hypovolemia, if you remember the pathophysiology that we talked about in the second slide, this capillary leak and edema that happens because of the endothelial disruption causes intravascular hypovolemia, and this is where patients need fluid. There's a general rule of 30 milliliters per hour, per kilogram within the first 3 hours. So for example, if someone is weighing 70 kilos, you give 30 milliliters per kilogram. So this will be 2,100 milliliters within the first 3 hours. And in order not to forget this, you can just say, any person that I see that is weighing like the normal population, I have to give 2 liters of fluid, a minimum of 2 liters of fluid within the first 3 hours. And we usually give crystalloids. We can give bringer, we can give saline, and we see how the patient responds to this fluid therapy. Is their blood pressure going up? Are they still as hypotensive as they initially were? Because this is also an alarming sign. If my patient is not responding to fluid therapy, if their lactate level is not falling down, then this means that I'm going towards septic shock. So my patient needs vasopressors. My patient needs catecholamines. Does this patient need an ICU admission? So the frequent reassessment in the management of sepsis is also very important. It is not just a normal diagnosis. For example, when you see someone coming into the emergency department with, let's say, a very normal urinary tract infection, you write everything down and they go to their ward. But someone who is in sepsis, you need to frequently reassess. It is an hourly reassessment that you need to do to see in which direction the patient goes. The management of sepsis since 2016 has this new definition of having to done a certain amount of things within 1 hour. So within 1 hour of seeing your patient, you must have taken your lactate level, you must have already taken your blood cultures, you must have given your fluids, and if needed, in septic shock, given your vasopressor therapy, and you must have given your antibiotics. The thing with antibiotics is we obviously start with empirical antibiotics. So we use broad spectrum antibiotics, and this is very different depending on which country we're in and which hospital we're at. I'm sure that in Syria is also very different than in Iraq and than in Germany and also in the USA. In Luxembourg, it's also different what type of broad spectrum antibiotics we use for patients who are suspected of having sepsis. But in the general run, within the first hour of seeing the patient, you have your blood, your cultures, your lactate levels, your fluids, and you've also started with your broad spectrum antibiotics. This next slide is a bit, it's for intensive care units, but I still wanted to mention it a little bit. There can be residents who will eventually go into the intensive ward. The measurement of blood pressure, the measurement of your heart function on the intensive ward is done invasively. That means you have a central line, you have an arterial line that measures your middle arterial pressure, and with these numbers we can assess in which direction the situation is going. So, for example, ZVP is your central venous pressure in your central line, which stands for your right ventricular and diastolic pressure. I don't know if this is a bit too complicated, but it is basically your filling pressure in your right ventricle, and this assesses your fluid status. So if this is under 8 millimoles of mercury combined with other measurements, then we can say, okay, this patient does not have enough fluid in the body. We need to give fluids. Your middle arterial pressure, if it's after fluid therapy, if it's still under 65 millimeters of mercury, we give vasopressors. Maybe you can screenshot these slides and use them when you're a resident on the intensive care, because I think when you have it summarized in a page, then it really helps. We also look at, for example, the O2 level in your central veins. This is also another important parameter on the intensive ward, where if it's under than 70, we say, okay, the tissue perfusion is not enough. Then we have to look, does this patient have enough cardiac output? Do we need to support the heart more? And this is done, obviously you have to look at the heart function, to look at the ejection fraction of the left ventricle. But I don't want to really go into that a lot, but basically if your cardiac output is not enough, do I need to give inotropes to the patient? Do I need to give dobutamine? Does this patient need blood in order to have a hematocrit level of about 30? There's also this other thing that I wanted to write down. I wrote it very small. If your central venous O2 level is too high, it is also not a good sign. We want it to be above 70, but when this level is above 80, for example, it states that that this patient is undergoing anaerobic glycolysis. I can simplify that by saying the central venous O2 level, when you measure it in your central line, basically means your blood cells are coupled up with oxygen. And when your tissue takes the oxygen, it takes it from the blood cells. And when you measure it in your central line, it's obviously decreased because during sepsis, your tissue needs oxygen and it takes it from your blood cells. So you measure a low level. But if you measure a very high level, this states that your tissue is so disrupted that it does not take the oxygen anymore. It has left aerobic glycolysis and it has shifted to anaerobic glycolysis. And that's why you have a high level of your central venous oxygen. And this is also when patients have a high lactate level. Like I said, this is a bit confusing, I think, but maybe take a screenshot and look at it when you eventually go to the intensive ward. I think it will really help because it has helped me. Okay, so signs of adequate resuscitation. Let's say emergency department, a normal ward, you have suspected sepsis, you have been very smart, you have taken your blood cultures, within 1 hour you have given fluids, and you're monitoring the patient. What are the signs that this is going in the right direction? Your blood pressure is going up. I mean, in the intensive ward, we say middle arterial pressure, but you can measure your systolic blood pressure. You see that the patient is urinating. This number of 0.5 milliliters per kilogram per hour is very important to keep in mind. You see that the patient is clearer in their minds. They're not that confused. And you see that your lactate level is falling down. I want to give a little example because I've had that as well. You can be one night called into a ward where an older patient is confused. They're running around the room. They don't want to sit down. And you go up to the patient and you see that they have a urinary catheter. You see that the urine is a little bit yellow, it's turbid, and the nurse measures the temperature and they have fever. And this should really alarm you to thinking, okay, I have signs of an infection. I see a urinary catheter. My patient has fever and they're very confused. And this is where you need to act quick and take your blood, looking signs for infection. You take you check the urine. You see the patient is hypotensive. You give fluids. These are things that you can also see in a normal ward in the middle of the night. If someone has a lactate of 3, you give fluids, the lactate decreases. And this is very helpful to manage these patients quickly. I dedicated a slide just to lactate because of how important it is in assessing the mortality of patients with sepsis. A lactate level of over 4 millimoles per liter is always an indication that you inform a doctor that is working above you. So always inform your senior on call, your senior on duty, if you have a lactate level of a patient above 4 millimoles per liter. So I'll ask my question again. I hope Dr. Haider can hear me again. If you have a blood gas analysis in the emergency department in Rojava. Okay, maybe I'll ask it again when I'm done.
Think, Dr. Haider, are you still there?
Of course.
Okay.
I just shut down my camera because we have some problem in internet.
Okay. But did you get the question?
Sorry, Simon, what?
Sorry, Dr. Haider, I asked if in the emergency department in Rojava, do we have a blood gas analysis?
Blood gas analysis, actually, just now, blood gas. I answer your question after your presentation, Dr. Roshan, because
okay.
for something I have to ask our friends here, of course.
Okay, it's okay. Yeah, thank you so much.
I hope you don't forget your questions.
No, I won't forget. Okay, so what is the additional diagnostic tools that we can send for once we have identified our septic patient? So like I said, the important thing about sepsis is acting quick. So you have your lab results, you suspect it, you start your therapy. But after you've started, there are also other investigations that you can send for in order to make your diagnosis more secure. So For example, lab, we already sent for it. An X-ray of the chest. This is also done in a matter of minutes if the emergency department, for example, is not very crowded. CT scan. This is also in certain cases the first investigation that you actually send for someone who has an acute abdomen. When you're an internal resident, I think you eventually after a few years you get the sense of gut feeling for a patient. What I mean by this is obviously when you treat a patient, you have your guidelines that you follow, you have your medical knowledge that you follow, but also when you see patients, after a while, you develop a feeling for them. So sometimes you see a patient and you immediately think something is not right. And I need to act quick. So an acute abdomen, when you see a patient who has excruciating pain, they've had surgery a week ago, CT scan immediately. You cannot slowly look at your lab results and see what what this level is and what this level means, what the kidney function is. Alarming sign to immediately send for a CT scan, but also a heart ultrasound, checking for the ejection fraction of the heart. I think this is also a step that we tend to forget in the beginning. More rarely, another cause of sepsis, for example, with endocarditis, when you have a vegetation on the valve. This is very, very rare that you see it from the outside. But for example, if someone has a suspicion of sepsis, they're on the intensive ward, and you've not really found the cause of your sepsis yet. You do a heart ultrasound from the outside, and you see that there's a vegetation on the, let's say, aortic valve. That's why heart ultrasound is also very important in the additional diagnosis of patients with sepsis. The differential diagnosis, like I said, the screening of sepsis is very broad. It is not just a few rules that you follow. And that's why there are patients who have similar symptoms, but they have something else. For example, patients with hypovolemic shock who do not have any sepsis can present with the same symptoms. Patients with cardiogenic shock could present with the same symptoms. People who have anemia, they also have tachycardia and they have tachypnea. People who are dehydrated in the summer when it's 35 degrees outside. People with congestive heart failure, they also have shortness of breath and tachycardia. They also have edema. People with cardiac tamponade, that is also it is also a medical emergency. People with pneumothorax, people with pulmonary embolism, but also, for example, pancreatitis, you also have an acute abdomen, people with other metabolic disorders, for example, diabetic ketoacidosis. These are all things that we have to keep in mind when thinking of someone having the possibility of sepsis. It could be an overdose, it could be a drug overdose. So it's also important to keep those in mind. Okay, what are the complications? So obviously what we talked about until now, the definition of sepsis, we said it is organ dysfunction. And this immune response leading to organ dysfunction. And this is also how we recognize it. So we said, okay, someone who does not urinate well, so acute kidney injury, someone who has jaundice, high levels of transaminases, so acute liver injury, someone who has ARDS, and what we mentioned previously, respiratory failure. These are all complications that can happen to the organs that need support eventually. Patients with kidney injury might need dialysis. For example, cardiomyopathy can also result from sepsis, where your left ventricle ejection fraction eventually decreases and can lead to heart failure. what we call septic cardiomyopathy. And these can all eventually lead to multiple organ failure and eventually also death of the patient. So I think it's very easy to remember the complications that happen along with sepsis, because it's also the same tools that we use for diagnosing patients. They're all related together. One other complication that we also see on the intensive ward in patients who have survived sepsis, in patients who have survived septic shock, in patients who have been intubated for a while and everything is over, you know, and now they're awake. Weeks have passed by, is what we call critical illness polyneuropathy. So you see, you know, you have followed up a patient for weeks on the intensive ward, and you notice that the patients have a paralysis of the extremities. This is usually the distal extremities. You know, they are weak, they have a muscle atrophy. This is usually due to an axonal injury that you have in your motor neurons. And you see this flaccid paralysis of the extremities. And sometimes they have this feeling of this numbness in the fingers. This is called dysesthesia in medicine. And this is where the neurologists also come into play. So there has to be, there are certain tests that we have to carry out in order to diagnose these patients, because these take weeks or even months if they heal, for them to heal. It can happen spontaneously, but it is also psychologically very degrading for patients who have been on the intensive ward for weeks, and then they have months of muscle atrophy. It can even lead to a myopathy. Patients can have a quadriparesis. And I think this is also where psychological help really comes into action for patients who have survived sepsis. Yeah, I think I'm done. I hope that I didn't talk too fast. If you have questions, I can repeat it. Please let me know. And thank you for listening.
Okay, thank you very much, Dr. Roshan. I think, as usual, I give a summary in the Kurmanji. Actually, we had some technical problem, and sometimes I didn't hear your voice very well, but I'm trying to give a summary in Kurmanji.
Okay.
Parastiyedi honji ditin gelek müşkile çebu mecib gelek şambaş fem nekir bas şekulu jimin rahat fem kirin az parve bikem zaten mejar sepsis bu yani di damaku او التهابات کو یا شگو چه دبه و پشتی او چغاز باندور نباش تکسر ارگان جدا جدا ایلاش infection outcome او انجام کو دردکوه یا هری گرینگ او کو داویه دا هم دبینین immune system response dysregulated به یعنی خراب ده به دستگاه مناعی مروف و داویه دا هم دبینین باندوره که نباش سر ارگان جدا دکن ناهلی ارگان کار خواب بکن مثلا گرچکتی سکناندن و هر وقتین zaten daviye beşeki jive sepsis bu xas septik şak bu ku edihun مجال septik şak baştır dizanın takriben se cure sepsis hat reskirin ku hat biramın yabalımın da bu o davi sepsis triku edi leve deme ya leve derece da organ dysfunction زیادتر تدیتن اوجی میگوید به صدم او کو پراسی پرگال مناعه هیا آسگیتی سکناندن یا باندور دبینه بحثا مورتالیتی کر کو مقیاس یا قیاس SOFA بکارتین جبر کو طبقه بندی کن یا دابش بکن بنیرن في سبسیس هيا چقاس شدت او هيا زياده هيا چقاس يكو جدولك اني لغوري او جدول دي ولو دابش تكر كو براسي چقاس خطري هيا او سبسيس چقاس سيفير يا چقاس شدت او زياده تره بحثا پاثولوژی یا پاثوفیزیولوژی سپسیس که کو بگشتی دما کو بحثا پاثوفیزیولوژی او دکن ام دبینین کو او مدییتور یا او مواد یا او تشن کو د انفلاماتور دا یا د التهابات دا رول دلیزن با او نازیدتر دبن یا حتی ام تشی کو وکو سایتوکین استورم کو مددید او ندما کو زیده دبن صدم دبن کو وزل یا دمارن دایلیت بن برفره بن جبویه پرو انفلاماتوری سایتوکینز او مواد سایتوکینز زیاده دبن قیاس دخوینی دا هر وها هم دبینین کاپیلاری لیک هی یعنی دمارین ولو وکری دبین صدم دبن یا خوین یا مثلا آویج کاپیلاری در که جبوی هم روش ادما دکارین ده سپسیس دا ببینین هر وها مشکلین ترومبوسیس یا مایکروواسکولار ترومبوسیس کوچه ده بو دیسا اوجی ده پاثوفیزیولوژی سپسیس ده ام دکارین ببینین هر وها بسدم کمبونا اکسیژن یوتیلایزیشن ام دبینین خطریا ایسکمیا و تیشو ایسکمیا هیا و داوی دیسا ام ودگرین ارگان دیسفاکشن یا کو ادید دبینی ارگان بگشتی نکاری کارو خوات خود بکا بحثا اتیولوژی اوجی کر یعنی صدم و مسئله چیه به تایبت دماکو پرگال رسپیریتوری به یا به عنوان به کو ادی صدم او نومونیای انفکشن نومونیای یا انفکشن کو دزدکی دا ابدومینال دا چه ده به وکو ابسس یا جنیتو یوریناری ده پرگال یوریناری به تایبت پایلونفریتیس اوجی یک اتیولوژین و نخوشی یا ریباز یا امبرژن سپسیس هر وها به تایبت implanted devices یعنی دما کو جهاز لاشه داتی چندن وکو کاتادر مثلا ده پرگال یوریناری دا اوجی دیسا صدم یا اساسن اتیولوژیه و هر وها انفکشن کو د چرمه دا د اندام دین دا چیده به اوجی صدم یا اتیولوژی سپسیسه به تایبت بحثا پاثوجنین کرد ام دزانی یک صدمین سرکه پاثوجن یا باکتریا یا جرثومات د باکتریان گرام پوزیتیو دا اگر شاش نبم استافیلوکوکوس آیروس و استرپتوکوکوس نومونیا یک باکتریان سرکه نه هر وها ده گرام نگاتیو دا باکتریان وکو ایکولای و کلپسیلا دکارن صدم بن یا وکو پاتوژن کو صدم سپسیس دکارن ببن هر وها د فانگای ده یا فطریات هم دکارن حیا اصلی کمتر صدم دبن اوجی فانگای وکو کاندیدیت اگر شاش نبم صدم دبه وکو پاتوژن ریسک فاکتورن کو هات عنوان کردن جبو سپسیس یعنی تشنه صدم دبن او سپسیس چه به یا خطری او زیاده به یک جوان مجاران ایجینگ بو یعنی دما کو تمن زیاده به او بو خود صدمه یک مسئله دین پرایمری کوموربیدیتیز یعنی نخوش کسی نکو زیاده الکلیسم مصرف الکل اونا هي استفاده ج درمانه نکو مناعه کم دکن ایمونو سپرسر براستی اونا ج ریسک فاکتورن وکو هر وها پرسکرینی کو د آی سی یو دا هي یعنی دما کو نخوش زیاده د آی سی یو دا دمینه به تایبت دم هیست یعنی به تایبت دما کو کاتادر یا اوجی صدم یا ریسک و ریسک فاکتور بکارانی کلینیکال فیچرز او یعنی اعراض کلینیکی او دی خویا یک جوان تشن هری گرینگ او بکو ارگان دهات سکناندن یعنی دبینی گورچک نا شغله نزانم ده مسئله الکتروکاردیا که دلی دا پرسکری که مسئله کاردیوواسکولار دا هر تشتی گوهارتن اعراض سپتیک شوک او شوک کود سپتیک دا هیا هون اوجی دبینه و هر وها primary infection features یا اعراض کود نخوشین التهابی دست به که دا مروف دبینه وکو فیور و هر وکودین عینی تشه لوه درجی تکرار دبه جبو منیجمنت و براستی مدیکال ایمرجنسی هندک تشان آنی زمان بلکو از باش نگیشم هر تش نویس کن بس براستی اسکرینینگ یا غربالگری پر گرینگ چاوای ام تحلیل بکن و چاوای ام کاربین حیا آستی که گریدای تجربه یعنی هندک دکتور که وکو امپریک یا تجربه اونا دوی مسئله ده به باش دکاره آلی کردیم مسئله کاردیاک مانیتورینگ یعنی او تحلیل کجبو دل چه دبه مسئله آی وی اکسس بو هر وها لاکتات سیوریتی مسئله لاکتات دخوینه دا پر زیاده جبر کو دبه سپسیس دا خوین اسیدوز دبه پی اچ دا دکوه دوی مسئله مدیریت کردن دا براستی بلاد کالچر بحثا بلاد کالچر کرد که لازمه دی عینات خوینه ورن چاندن هر وها لازمه ام هموداینامیکس و رسپیریتی ساپورت پیوسته یعنی لازمه جهازن کجبو بندان یا رسپیریتوری پیوسته نامه بکار بینین بحثا فلوید رساسیتیشن که لازمه ایدی فلوید یا چه ده بجن ساعده و تشنو که لازمه همه بدین بسایبت کریستالوید کو اگر شاش نبیم حیا CML ده کیلوگرم ده 3 ساعتی دا گوت همه بکار بینین و استفاده جه وازوپرسورز وکو وازوپرسین کو اوجی دیسا بکار بینین و اکید مسئله آنتیبیوتیکات بکارن آنتیبیوتیکات ده ساعت دست بگی ده پر گرینگ بو کو براستی نقاش من سر به مسئله آنتیبیوتیکات پر هر وحد مسئله تشخیص ده هند ریباز و جهاز دیگه گوت وکو ایکس ری اشعه و آلتراسوند و سی تی و اکوکاردیال کو دیز بحث اون کم بتایبت سر دیفرنشیال دیاگنوستیس چی بحث کرد کو ام دکارن دروی او تشخیص سرکی دست بگم دیساورین ارگان یا عضو ام تشخیص بدن وکو کاردیوواسکولار دیاگنوستیس مسئله رسپیریتوری توکسیکولوژیکال دمجار جحره دا ام دکارین تشخیص خود بدن بحثا کامپلیکیشن کرد کو یعنی او خطرین کو تشنو کو چه دکا براستی مگوت یا هری داوی ارگان دیسفانکشن کو ارگان جدا تین سکناندن وکو ARDS اگر شاش نبم اکیوت رسپیریتوری دیسترس سیندروم کو صدم دبه کو مشکلی که جدید رسپیریتوری چه به AKI یا اکیوت کیدنی اینجری یعنی گرچک خرابه به MOF یا مالتیپل ارگان فیلرز یعنی گلک جو ارگانل یا عضوین ما مشکل چه به و هر وها CMP هبو تقریبا از باورم تشینه کو هات کو تن او بو هندک بلکو تشان جمل گوندا کر براسی جبر کو دنگ گوندا بو بس دو پرسکی دکتوره هبو دکتوره روشن که گلو جهاز بلاد گاس انالیسیس جمع های یعنی ام دکارین گاسین خوینه تحلیل بکن این براسی جبر کو آگاهی من تنبو اظن اگر آگاهی که وهای لور نظر یا جهاز کو گاسین بلاد فاکولته ما ده هي نه لور يعني فاكولتي ما تونه تروي نه انا فاكولتي تمام نظام هاگر تشک مجبور که ببورن براستی هی زمان حیابی مسئله بو هاگر پرسه که وحی نیرینی که وحی تشکی وحی که دکتر مریم تو باره هری که من بده ناس کریم Okay, I try to give a summary of your presentation, Dr. Roshan. Maybe I forgot some slides. Sorry, but I think everything was clear. Let me introduce you, Dr. Mariam. Dr. Mariam is co-president of medical faculty.
ايوه ادم باش شلون باش مساعد خوش دكتورة راسية بموضوع قلكي مهم بو وخاصة فيدد باجاري مدى بسيبسيس قلكي إجارية جبر تعقيم لوام راسينة قلكي بس مشكلات ما هي بسيطة إني زرع دم جهاز زرع الباما تنيي إجا يعني حطام بقين جرسومة مسبب حطاه بتغطية كنا ما بسكريك جمال شيء كان الساعة خوش
Gelijk spaas. كل ما نجي عملنا باشا يعني وحنك أخو مربكن لفركو كل ما نجي عملنا باشا بس I asked Simon I think for blood cultures Simon because they're saying that they don't really have it and they have to send it away and it takes a really long time until it comes back. Yeah, this is what she said.
Okay.
Yeah.
But where do they send it to? Where's the laboratory?
هون كلتشر أخو لكوي تشيكن هون and لكوين دري وينفع سوا. She said you don't have the blood cultures and you have to send it away. But do we know where it is? Dr. Haider?
Yeah, I don't understand you, Dr. Roshan. What?
She said the blood cultures that we do in Syria. She said we don't have it, so we have to send it away.
Yeah, do you know what's the problem, Dr. Roshan? Altogether in the north and east Syria, and of course, I think in the all Syria, there is some deficiencies in microbiology. And of course, clinical laboratories are not professionally working on identification of bacteria. Just now, we are started to identification bacteria, especially in the molecular base. For example, we are using specific primers and. But for the blood cultures, yeah, we started some project in the Masters of Microbiology, and the part of project was on the blood culture. But unfortunately, we couldn't find some staffs. But we are still trying in the university to set up blood culture. But I have one question in your speech and your presentation. You have talked about blood culture in 2 minutes. You sure? And I wanted to know what system are you using.
No, I meant taking up the blood. Obviously, the result takes a few days until it's there, depending on if it's positive or not positive. But I meant it is important that before we start antibiotic therapy, that we take the blood. And the taking of the blood, سحب دم, it takes a few minutes. That's what I said.
Yeah, of course. I was surprised that you do culture in 2
No.
And of course, you had the question that do we have blood gas analysis? Actually, in the faculty, I asked our friends that there isn't such a device in our laboratory, but of course, there is in hospitals and other centers, I think. Dr. Roshan, actually, the topic is very, very important, especially for our region, for Rojava, for Bashu, Rojhelat, because we have a very, very wrong culture in antibiotic consumption. Okay, we have a super resistance bacteria, and for management, you are talking about using antibiotics, but our bacteria are resistant to antibiotics.
Yeah.
And yeah, we don't know what do we do.
Yeah, this is why I also did not talk about antibiotic therapy, because I worked in Slemani for a few months before I came here, and the use of antibiotic therapy there is very, very different than here. You know, a patient comes to the hospital, and you know, sometimes they start immediately with meropenem, and here meropenem is one of the last choices that we go to. So it's two different worlds. that we cannot compare the antibiotic therapy. And I knew that it will not be useful if I talk about the antibiotic therapy.
Yeah, you have talked about maybe, I don't know, 10% or maybe 20% of mortality. But I think the rate of mortality may be more and more here in our region because of
Resistance.
a lot of reasons that you don't know.
Unfortunately.
Anyway, I think there isn't any comments and everything is okay here. We appreciate your presentation, nice presentation. I hope we have more collaboration between you and Rojava University.
Yeah, I hope so too. Maybe I'll practice my Kurmanji and the next time I'll do it in Kurmanji.
Okay, thank you very much. Of course, I hope next time you speak in Kurmanji. It's not acceptable to course people talking in another language. And yesterday was the mother language world days, I think, yeah? روز جهانی زمان کردی پیروز بود.
گلکس روز پیروز.
ساعت و خوش دستی و خوش به سپاس کم ایوای سرکوتن بو ایوا با دکتر اکرم و گروپ آیش. Thank you very much, Simon. Thank you very much, دکتر اکرم.
Thank you.
ساعت خوش دکتورا.
گلکس باس.
هلا ساعت.
دکتر سیمون دخواست بودن دعوی بیجه چون که بگید ایرونل بره.